All right, good morning, everybody. I got 9:05. Thank you for being here on time. I want to honor and respect the fact that you did get here when you were supposed to. We're going to continue with our lecture on cardiac pharmacology. Just a couple things to remind you. What we cover today, as far as pharmacology goes, will be fair game for your exam 1 week from today, and we'll do a review on Monday of the exam. Um, I will go in and take a look and make sure that there is the study guide that is listed on there. And the thing that I would tell you to remember is that all the questions are going to come from that particular type, from that particular study guide. So again, today's lesson will be recorded just in case you want to go back and you want to review it. The other thing I would tell you is so far this semester, you guys have been awesome. One of the top classes as far as participation and discussion. And one of the downsides of doing a Zoom-based class is participation has a tendency to drop down. So let's not break that. Let's not break that string of victories that you've got going on there, and let's participate the whole time today. So now, before we jump into the review session or into the additional on pharmacology, anybody have any questions? Anything we need to discuss today? First of all, did everybody? My apologies, and thank you, Jack and Z, for pointing out that fat fingers clicking too fast. Did everybody get the link for today's 320 class?
Yes.
Awesome. Okay. If you did not get the link today, please shoot me an email and let me know, and I will send that back out to you. But again, anybody have any questions before we jump into the lecture today? All right. Hearing none, let's get started. We share the screen, and let me get back to my PowerPoints. All right. So, Travis, are you able to see the kind of the purplish slide that says September 18th?
Yes, sir.
Excellent. Thank you. All right. So, continuing on with, and this is just basically, like I said, it's going to be a review of pharmacology that you learned in 225. Now, again, we finished up with my favorite cardiac drug of all of them, just simply because it's a good drug, but it does some weird things. Now we're going to go into another A drug that in many situations it's entirely different than adenosine that we talked about. And this is amiodarone. Now, amiodarone is classified as a potent type of antiarrhythmic agent. And it is a first line antiarrhythmic that we give during cardiac arrest because it has been proven to improve the rates of ROSC, especially with adults, not so much with kids, but with adults who have refractory VFib and pulseless VTAC. Now, let me stop there just a minute and ask a question. When I say the word refractory, what does that mean? Just unmute and tell me.
uh, the refractory period. It's a part of the T wave, if I'm not mistaken, if I'm getting my lingo right. It is
Okay.
the
So you're not wrong, Tanner, but much like English is an interesting language, refractory can have more than one meaning. What you just said about the refractory period with the T wave and the absolute and the relative refractory, you're 100% correct. But in this situation, refractory means a little different. So refractory just simply means it doesn't react well to normal treatment. Now, let me ask you guys a question. Under normal circumstances, what is your initial treatment for VFib and pulseless VTAC?
Defibrillation.
Defibrillation, yeah. So Again, refractory just simply means that it does not react well to defibrillation. Okay, we defibrillate, it stays in that ventricular type of rhythm. So we defibrillate, it stays in VFib or pulseless VTAC. Amiodarone is going to be the drug that you're going to utilize to help with that particular process. Now, here's how it works. So amiodarone will prolong the action potential in all of the cardiac tissues. Basically, what it does is that it lengthens out, again, coming back, Tanner, to what you just said a minute ago, it lengthens out that refractory period to hopefully allow a normal pacing site to take over. Generally, what we see is that amiodarone works best when it's used in conjunction with defibrillation, and that's a good thing because that's going to be our primary treatment. Now, when we're looking at the chemical action of amiodarone, is it affects all three important cardiac electrolytes. And so, Z, what are the three primary cardiac electrolytes that we as paramedics are most concerned about?
Sodium, potassium, and calcium.
Perfect. So it sounded like a Star Trek movie there, a little bit of reverb going on in the back. So yeah, you're exactly right. So basically what it does is it helps to change those channels. Remember, we have the sodium and the potassium pump that come in and out, in and out, in and out. And then we have calcium. And remember, the sodium potassium pump deals primarily with the electrical impact or the electrical stimulation of the heart. The calcium deals with the mechanical action. Now, here, the other thing to remember with amiodarone is that it has both alpha and beta blocking properties. Okay, so if it blocks the alpha receptors, Blake, I'll come to you. If it blocks the alpha receptors, and remember which alpha receptors you and I are most concerned about as paramedics, what impact do you think that is going to have on our patient? Blake Muncie.
Sorry, I thought you was talking about Parman.
That's okay. My fault. My bad.
I'm honestly not sure.
Not a problem. So if we block the alpha receptors, again, the alpha receptors we're talking about are the peripheral vasculature, arms and legs. So if it blocks those, one of the side effects of amiodarone is it can drop our blood pressure. Okay. If it blocks the beta receptors, then it's also going to have that impact very similar to beta blockers that we'll learn about here in a little while, as far as those impacts on the heart itself. Now, here's what I want you to know about this particular site is, first of all, the onset starts in about 1 to 3 minutes. So it begins to work really, really quickly. The duration varies, and much of that varies depending upon the patient and depending upon their renal and their hepatic abilities to filtrate this drug out. But here's the other thing I want you to really, really look at. Look at that half-life. This is going to be in our patient for a very, very long time. But again, here's the thing you got to remember. For us as paramedics, we're going to be using this in an emergency situation. The other thing to keep in mind is sometimes patients will take this in a tablet form on a therapeutic basis, a long-term basis. So again, if they begin having side effects of the amiodarone that we're going to give, it's possible that they're going to have this for literally for months, that is going to stay in there. 2 indications that we're going to see for amiodarone: VTAC with or without a pulse, okay, and VFib. VTAC with and without a pulse, and VFib. Now, there are some contraindications that we want to look at, and these are relative contraindications. So again, Kelsey, when I say relative contraindications, what does that mean? Because that's an important word, relative, in pharmacology.
Like something that's happening right at that moment.
You're close. Relative basically means we're going to look at the patient and we're going to do a risk benefit analysis on whether we're going to give this medication or not. Remember, we talked about right-sided MI with patients who have the administration of nitro. If their blood pressure is fine, we're going to go ahead and still give them the nitro. But if the blood pressure is, even if it's down on the lower end of normal, we may hold off on that. So relative contraindication means if you have 3 different patients that are presenting the same way, VFib, VTAC, pulseless, or with a pulse, we're going to dig a little bit deeper because in certain situations, we may give amiodarone. In certain situations, we don't. Well, first of all, and the first one here should actually be 2 different contraindications. Number one, a relative contraindication is going to be for females who are breastfeeding because that amiodarone will be passed right along into the baby, and we don't want that to happen, okay? The second one is going to be patients in cardiogenic shock. Now, Jack, what I want you to do is to remind me basically what's the mechanism behind cardiogenic shock?
Is it that the heart is not pumping correctly?
Perfect. Remember that, guys, especially as we're dealing in here. So when we're talking about cardiogenic shock, we're basically talking about the heart has pumped has failed as a pump. If our patient is in cardiogenic shock, then we're going to want to step back and say, okay, will this be the best for our patient? All right. The last one is going to be a condition that's known as sinus node dysfunction. And basically what this does is the sinus node is messed up. It used to be called sick sinus syndrome, SICK, sick sinus syndrome. And what happens here is that we get either a really, really low bradycardia or we get a high degree AV block. Now, from yours and my perspective, we're really not going to know that unless we can pick it up on the patient's history, because sometimes that they will tell you, well, this is what I've been diagnosed with. And again, in this situation, we're probably not going to give it because it's really not going to be indicated in this particular situation. The last one here is use precaution with heart failure patients. Again, this comes back to what Jack said just a minute ago of the failure of the heart as a pump. And remember, it has beta blocking properties. And as a result of that, we're going to reduce the contractile force. And what else will we reduce if it's a beta blocking property? The amazing Haley, you tell me, what with beta blockers, what do we reduce?
Correct me if I'm wrong, but beta tends to more play on the lungs, so possibly the respiratory drive goes down.
So, okay, so you are spot on there as far as now. Remember, we have beta 1 and beta 2. There are some concerns about utilizing amiodarone with patients that have asthma because it does have an impact on the lungs. But when we're looking at this with heart failure patients, if it blocks the beta receptors, it's going to reduce the heart rate. And that may or may not be the very best thing that we're going to do for our particular patients, okay? Most of the time, we'll talk about a situation where these decisions that you're going to have to make are going to really come into play here. But most of the time, you're going to give amiodarone in the condition of a patient having a cardiac arrest. Occasionally, we'll talk about if you've got patients that have unstable ventricular activity, bunches and bunches of PVCs or VTAC with a pulse. Now we got to come back and we got to think about this. All right. Here's your side effects. Number one, it's going to drop the blood pressure. Why is it going to drop the blood pressure? Well, it blocks the actions of the alpha receptors, opens those vasculature up, blood pressure begins to go down. But wait, there's more. Bradycardia. When this is slowing down the heart rate, it is also going to now begin to reduce our blood pressure. So those two things fit into each other to drop that down. Now, Caden, what does ventricular ectopy mean? What does that phrase mean? Because it's going to increase it, and this is an important thing to know as far as the side effect.
Like, I guess an ectopic or something on an EKG that's ventricular in nature.
Okay, and what does ectopic mean? You're on the right track. Give me a little more information.
Like an abnormal beat or something.
Perfect. Perfect. So it's an abnormal beat arising from the ventricles. Now, what's really interesting here is that we're going to give amiodarone because they got a bunch of abnormal beats that are arising from the ventricle. But you got to remember one of the side effects is that not only can it eliminate those, it can actually increase them as well. The other thing we're going to see in here is that we can get prolongation of the PR interval, okay, the QRS, and the QT interval. Now, Blake Parman, let me ask you a question. Let's think about this. Go all the way back to 303 in that foundational course. If we lengthen out that PR interval, what is going to most likely be the end result of that?
Well, on the EKG, it'll kind of start with a first degree block, and then it will just kind of get worse and worse from there, going from where it could start dropping beats.
Perfect. And the end result of that is going to be what for our heart rate?
Well, it's gonna plummet the heart rate.
Yeah, you're exactly right. So it comes right back up here. Let me grab my little laser pointer here. It comes right back up in here. This is why it's going to have a potential for an increase in bradycardia. All right. Now, Naomi, let me ask you. We're concerned about the widening of the QRS, but that's more of an indicator than a really concern. But what we are concerned about is if this QT interval continues to widen and widen and widen, what could be the outcome of if this QT interval gets really wide? So this is for Naomi. Am I coming across there? Oh, looks like somebody may have. Hold on. Oh, our microphone's not working. Gotcha. Okay, not a problem. Wyatt, what do you think? What's the problem if we get this QT interval? Think about what's happening in that time frame. So Wyatt, as it goes across, what is the big concern with that QT interval getting wider?
So as it gets wider, we're looking at the ineffective ability of the left ventricle to act as the pump, which that's where we're seeing more like a left or right bundle branches when it's starting to get wider. We also see like VTAC and torsades with that wide QRS.
Yeah, very good. And so the main reason for what you just said, for all of those things that can happen, is remember, the QT interval is when the repolarization of the ventricles takes place. As that lengthens out, remember, one of the principles or one of the underlying principles in the physiology of the heart is that every cell can generate its own impulse. If that QT interval gets wide, eventually there's some place, most likely within the ventricle, that's going to fire off. And Tanner, we'll come right back to you a while ago. What did you say? If it hits on the relative refractory period, now what happens to our patient?
And send them straight to VFib.
Yeah, you're exactly right. They go into VFib. We get ROT, and basically our patient goes into VFib. So in particular, this is going to be more of a concern for you for patients that are taking this on a long-term basis than it would be for the administration that you would give for emergency use only. Okay. All right. So let me see why my remote is not working here. There we go. All right. Here's your dosage. When we've got a patient in cardiac arrest and the presenting rhythm is VFib or pulseless VTAC. Okay, now remember, VFib and pulseless VTAC, when we get into AHA algorithms, they are treated exactly the same. You have to be able to identify them, Rebecca, but they are treated exactly the same. And one of the drugs that we utilize here is going to be amiodarone. We're going to give an initial bolus of 300 milligrams, and we're going to give that IV push. Okay. We can repeat that in about 10 to 15 minutes at half of the dose. We're not basically going, and we don't want this to be given in a drip. We want to get it in, all in one dose. Okay. We're not going to worry about pushing it in like we would say with adenosine, but we do want to kind of do a nice regular bolus to get that into the system. Again, remember, it's 300 milligrams IV push, and then we can repeat it in about 10 to 15 minutes at half that dose. Now, the other thing that we will do here is that if we have symptomatic ventricular arrhythmias, with the exception of torsades, okay, if we've got multiple PVCs, if we've got especially multiple multifocal PVCs, or we have VTAC with a pulse, we would give amiodarone 150 milligrams IV over 10 minutes. And basically what we would do is that we would take a 100 milliliter bag of normal saline, inject the amiodarone into the bag, and then we would just either set it up on our pump, and we'll do a little bit of drug calculations as we're moving a little bit farther in to kind of refresh that as well. But we would set it up on a pump, or we would set our drip rate to be able to give that over 10 minutes. All right, Eli, not a problem. It's the joys of distance learning, so I fully understand. That's why we're recording this. Okay, that's our information on amiodarone. Let me stop. Anybody have any questions on amiodarone? All right, let's go to another very, very familiar drug that you're going to need to know, and that's atropine. Classifications of drugs are going to be really important to me. So knowing that the different classifications that these drugs fall in helps you to also know how they're going to work. So it is classified as an anticholinergic, okay? It is a parasympatholytic, okay? Now, Victor, what does that word mean? That's a really big word for early in the morning. But when I say this particular drug is a parasympatholytic, tell me what that means. I think you're muted.
I don't know.
There you go. Say it again.
I don't know.
Okay. Somebody help him out now. What is a parasympatholytic? Anybody just jump in there.
It's a substance that helps reduce the activity of the parasympathetic nervous system.
Perfect. And what is the parasympathetic nervous system? Let's stay right there with you. That was awesome.
It's what's it? Okay, so it's not fight or flight, but it's I don't remember.
All right. So what's the opposite of fight or flight?
It's the rest and digest.
Very good.
Yeah.
Yeah, very good. So basically, again, the parasympathetic system drops down everything. So especially from a cardiac perspective, what it does when cholinesterase, and that is the chemical receptor that is secreted, when it's introduced into the heart, it reduces the heart rate. Now, part of the problem is there could be a number of reasons why this comes about. And so it comes and what we want to do is we want to block that. Okay. Now, atropine is used to raise the heart rate in our patients who have symptomatic bradycardia. Okay. Now, Tanner, give me an idea of what a patient would look like that has symptomatic bradycardia.
Would it be organophosphate poisoning?
Say it again for me. You were kind of muffled.
Organophosphate poisoning?
So we're going to talk about organophosphate poisoning here in just a little bit because that does come into play here. But if you've got symptomatic bradycardia, remember you've got a bradycardia that is causing your patients perfusionary problems. So generally what we're going to see is we're going to see a lowered blood pressure. We're going to see a patient that is lethargic. We're going to see a patient that maybe is even having chest pain, showing signs and symptoms of shock. So it is just the issue of our patient not being able to perfuse enough blood. Now, again, and this is critically important, is that we utilize this when our patient is symptomatic, because there's certain times that a person will have a bradycardia that's not a problem. You go to sleep, almost always, especially if you're wearing a smartwatch, you can go back and see what your heart rate was during the night. Generally, it will drop down below 60. That's a good thing. It's supposed to. That helps us to sleep. You have those of you that do long distance running, weightlifters even will have a reduced heart rate, but that's not symptomatic. Okay, so we want to look at that. So basically, what it does, though, as far as the mechanism of action, and this is important for you to know because you'll see this on your exam, is that it blocks the acetylcholine receptors. So remember, we have different receptors on the heart. And so when this acetylcholine is secreted out, it goes to these receptors, links up with them to slow down our heart rate. So basically, it's kind of like Narcan for the heart. It blocks the action of acetylcholine from attaching to those particular receptors, and thus it inhibits parasympathetic stimulation. Now, here's the thing that you remember, is it will increase your heart rate, but it has little to no inotropic effect. Now, Juju, when I say little to no inotropic effect, what did I just say? You're still muted.
Yeah, my taskbar was in the way and I couldn't unmute myself.
You're okay.
Isn't entropy like the contractile force, or is that something else I'm thinking of?
Nope, you're exactly right. So remember, entropy in and out, contractile force. So it's not going to help the heart eject more blood by increasing the contractile force of the heart, but it will help the heart to eject more blood by increasing the heart rate. Now, much like Tanner said a while ago, it plays a really, really important role in organophosphate poisoning. And we're going to talk about the dosing regimen for organophosphate here in just a little bit. If we give atropine, typically what happens is it begins to work right away. Okay. And if it's going to work in our patient, it's going to begin to work in about 2 to 3 minutes. So we're going to see a quick result in that. Your half-life is going to be anywhere from about 2 to 3 hours. Generally, what we're going to see with this patient is that when we're administering atropine, and we can give 3 separate doses of atropine to help to increase his heart rate, if it's going to work, we'll often see it work by the first or the second dose, Catherine. If it's not working by the second dose, we can still give that third dose, but most likely it's not going to work, and we're going to have to go to back to our backup plan, which would be transcutaneous pacing. 2 primary indications that we're going to be giving for our patient. Number 1, symptomatic bradycardia. Okay, let me stress that to you: symptomatic bradycardia. The other one is going to be organophosphate poisoning. With organophosphate poisoning, basically what we see happening And those of you that are in the military, you're probably really well versed with this because I'm sure that they beat this into your brains as part of your training, your education, is that we have this mnemonic that's called sludgem. Basically, sludgem, SLUDGEM. Sludgem stands for salivation, foaming at the mouth, lacrimation, just our eyes tearing up, urination, defecation. G and E go together. Gastric emesis, or patient vomits and vomits and vomits. And then the last one is meiosis, which is basically the dilation of the or the constriction of the pupil. And we give atropine to reverse those symptoms. Now, the interesting thing about atropine is that the dosing regimen for those two different situations are entirely different. As far as contraindications, again, if I ask you about this, what I want you to simply tell me is that there are no contraindications in the emergency setting. Because again, remember, you and I have talked about this of having a hypersensitivity or an allergic possibility of an allergic reaction to this is going to be true for all of our patients. Now, here's the thing you got to remember. Number one, you want to be careful when you're giving atropine to a patient who has coronary artery disease. Travis, why? Looks like you're still muted. There you go.
You could be increasing the strain on those vessels.
Yeah, you're exactly right. Remember, when we increase the heart rate, when we increase the contractile force of the heart, we're also increasing the workload. We're increasing the cardiac demand on the heart. So again, when you're looking at this particular situation here, you want to kind of weigh it. Okay, my patient, I'm looking over here at my 12 lead, and it looks like my patient's having an MI, but he's got a heart rate of 30. Again, which one is going to kill your patient first? And ladies and gentlemen, I wish I had, again, and you'll hear me say this on a regular basis, I wish I had a hard and fast rule to tell you of when you would do what. But that's the whole beauty of medicine, is that you have to critically think and come up and do what's best for your patient. Okay. Again, if you give atropine, that ischemia could worsen. But again, if we don't give atropine, there's a possibility that our patient is not going to survive, primarily because their heart rate is going to be so low. Now, here's the thing to remember. If you give atropine to a patient with high degree block, okay, there is a possibility that you can make it worse. All right. There's a relative contraindication for atropine with high degree block in the fact that, number one, like you said, or like I said, it can either make the block worse, or number two, it just doesn't do anything at all. So again, with high degree block, and by high degree block, what I'm talking about here is second degree type 2 and third degree block. If we have that type of a situation, do not delay pacing to give atropine first. If there is any delay at all to getting your pacer up and running on your patient, go ahead and give them one dose of atropine. 99 times out of 100, it's not going to work. But if I'm that 100th patient, then that's going to be pretty important to me, and it's going to help. All right. So again, what we're going to do is we're going to give atropine 1 milligram IV push in the cardiac situation of up to a total of 3 milligrams. Why do we stop at 3 milligrams in the cardiac situation? In a minute, we'll talk about where you're going to get almost like gallons and gallons and gallons of atropine for organophosphate poisoning. Well, with 3 milligrams, research says that we have completely blocked the receptors that the acetylcholine is going to come out and attach. So basically what we're doing is we're giving a medicine that's not going to have any benefit for our patient and could potentially have some harm if we give it greater than 3 milligrams in symptomatic bradycardia. Some of the side effects we're going to see here is your patient may complain of blurred vision. If they are complaining of blurred vision, it's because they've got dilated pupils. If you've ever been to the optometrist or an ophthalmologist and you go in and they say, well, we want to look inside your pupil, they drop in some drops. Basically, what they're dropping in is atropine. It causes those pupils to literally blow so that they're able to see in, but it makes it a little more difficult for us to be able to see. It is also, it will dry up secretions in the body. At one point in time, they used to give it for patients going into surgery to reduce the amount of secretion so that there was less of a problem of an airway issue. It can also result in a rebound tachycardia for our particular patients. Here's your dosage. And the only thing I'm going to test you on as far as your dosage, I'm going to talk a little bit about organophosphate in just a minute, but I'm only going to ask you to know that your dosage is going to be 1 milligram. We can repeat it every 3 to 5 minutes, pretty much the same regimen as we were talking about with the epinephrine. We can give it up to a max of 3 milligrams. Now, if we are dealing with organophosphate poisoning, now Bluegrass Army Depot is shutting down. They've done their job. They've done a good job. There's been no incidents there. But the agencies around central Kentucky carry tons and tons of atropine in case of a leak of organophosphates. And basically what you will do is you will give 1 milligram every 3 to 5 minutes up until those signs and symptoms of sludgeon begin to dissipate. You know, secretions begin to dry up, the eyes watering goes away, the vomiting goes away, the bowel movements go away. So just kind of hold on to that because I'm sure that you'll cover that in med emergencies. But the big thing is to remember, here's your dose for atropine. Questions about atropine? Diltiazem, all right? Diltiazem is a calcium channel blocker, okay?
I had a question about atropine, sir.
I'm sorry, go right ahead.
Why is it not generally indicated in cases of cardiac arrest? Wouldn't it be effective with something like PEA or?
So good question there, Travis. We don't use it in situations of PEA because what's missing in PEA?
Contraction.
Yep. Very good, sir. Yeah, excellent. And so what we're trying to do is we're trying to speed up the rate of contraction. And again, in PEA, all we have is just simply electrical activity. So atropine is not going to have any effect on the contractile force. Remember, we talked about it has little to no effect on the contractile force. So it's not going to bring back that contraction of the heart. Now, Travis, let me ask you a question here. What drug can we give that will have a positive impact on the contractile force of the heart? Epinephrine. You're exactly right. That's why we're going to give that epinephrine every 3 to 5 minutes until we get a perfusing rhythm back. Does that help?
Yes, sir.
Awesome. Excellent question. Anybody else? So Wyatt, if we block the calcium channels in the heart, what's the end result here? What happens?
You're going to slow down how much it actually physically contracts. You're not messing with the signals necessarily as much, but it's just physically not going to be able to contract that fast.
Excellent. Very, very good. So again, diltiazem helps to relax smooth, vascular smooth muscle. And if it relaxes, now what's going to happen is we're going to get some vasodilation. In certain situations, that's good. And then it's going to slow that conduction through the AV node by way of blocking calcium. And just like Wyatt said, it's going to help us to be able to reduce the workload on the heart. Now, as we're looking at this, it can be utilized in the treatment of angina because of that reduction of the inotropic action. Remember, if we increase inotropy, we're going to increase the workload and increase the possibility of ischemia. If we reduce inotropy, we do the exact same thing. Here's the other thing, is that not only does it generally have vascular dilation everywhere, but in particular, it works really, really well on the vasculature of the heart. Now, again, why would we want to dilate the blood vessels in the heart? Because, again, if we've got a blockage, we got to get some blood around that blockage because time is muscle. That's why it's really, really important. It will begin to work in about 3 minutes and it peaks out at about 7. Now, our half-life is going to be 2 hours. And so that's why many times diltiazem is going to be a drug that you're going to start out in the hospital. So when do we give it? What do we do? Well, first of all, if we've got symptomatic SVT, this works really, really well because now it slows down the contractile force of the heart. And because it slows down the contractile force of the heart, it will allow more blood to come in, increasing preload. And remember, if we increase preload, we increase cardiac output. And then it is also really, really good in the treatment of atrial fibrillation or atrial flutter that is really fast. Now, once we get into talking about ACLS, you'll learn that sometimes you can have atrial flutter with what's known as an RVR or a rapid ventricular rate. We don't want to give that patient adenosine because now basically what happens is that all of those little F waves, remember those F waves are just little depolarizations from multiple places, many, many places in the atrial. Think about what would happen if we allowed all of those impulses through. Our heart rate would go up really, really quickly and our patient would die pretty fast. Contraindications, again, if you've got a patient that has really, really low blood pressure, if they have some type of heart failure or cardiogenic shock, again, this comes back to what Wyatt said a while ago, is that because it has a direct impact on the inotropic effect of the heart, basically we're looking at the possibility here of making cardiogenic shock worse. It is also contraindicated in wide complex tachycardia. Okay, it's indicated in narrow complex, contraindicated in wide complex. Now, here's the thing, and we'll talk more about WPW a little bit later on, but just kind of put this in your back pocket. WPW, real brief, WPW is a reentry type of rhythm. Basically, what happens is that we have a circular motion, usually somewhere up at the atria, where we have one impulse that just gets circulated and redepolarized on a regular basis. It's kind of like you get on, if you go to Gatlinburg, not Gatlinburg, but Pigeon Forge, and you get on those go-karts, you get on a track and you're going fast, but you're only going around and around and around in a closed track. Well, something similar happens with WPW. And because of that will raise our patient's heart rate. We'll talk more about that a little bit later on in the semester. Be sure that your patient does not have WPW or Wolff-Parkinson-White syndrome if you're going to give diltiazem. So I don't expect you to know what WPW is to that extent just yet, but just know that it is a contraindication. Keep in mind, watch your patient's blood pressure. Okay, watch your patient's blood pressure because it can cause them to bottom out like crazy. If that happens, then we're going to give our patient calcium chloride. Why? Because with diltiazem, we've given them a calcium channel blocker, and now what happens is we give them calcium chloride and we send the cavalry in and we give them a bunch more calcium to override that. Now, If you've got a patient that overdoses on diltiazem or any other calcium channel blocker, this is why, if you have not done so, I strongly encourage you to download the Hippocrates app, because it will go in there and it will tell you bunches and bunches of information about different types of drugs and pharmacology. And so the big issue that we're looking at in here is that anytime you have a patient that has a calcium channel blocker overdose, then what we're going to do is we're going to flood that system with calcium, usually either by giving them calcium chloride, or there is another variation of it called calcium glutamate. Side effects, obviously, side effects of reduced inotropy, slow heart rate, reduction in blood pressure. As a result of that, our patient can begin to have an altered mental status. It worsen or start up actually a heart block. If your patient is taking a beta blocker, that is going to be a contraindication because they do not work well together. Okay, remember, if our patient is getting a diltiazem, a calcium channel blocker, we're reducing the inotropy of the heart. If they are getting a beta blocker, we're also reducing the heart rate. So we're taking two things, putting them together, and we increase the risk of our patient having heart failure, bradycardia, or going into a systole. Here's your dosing regimen, okay? So we're going to give this IV, and we're going to give it somewhere between 15 to 20 milligrams, again, basing upon the severity as well as the size of your patient. And we're going to give this over 2 minutes, okay? We can repeat it if we don't get the desired response, or if our patient doesn't begin to crash in 15 minutes. Now, if we get a good response and our patient's heart rate is beginning to slow down, and we still have good control of a patient's blood pressure, we're going to start an infusion rate, and we're going to run that between 5 to 15 milligrams per hour. I would tell you on your infusion rate, like most everything else, start low and go slow. So start them out at 15 milligrams, or 5 milligrams, not 15 milligrams, 5 milligrams per hour. And then you can increase that depending upon how much time that you have as far as your transport time is. Questions on diltiazem? Dopamine. Dopamine is an old drug, and it's been around for ever how long there have been humans, okay? Why do I say that? Dopamine is a naturally occurring catecholamine that you and I are producing in our body right now. It is a type of norepinephrine that acts on the alpha and the beta 1 and the dopaminergic receptors, okay? The dopaminergic receptors have a direct impact on our patient's blood pressure. Why do we use it? Well, it's used in the treatment of symptomatic hypotension that is associated with cardiogenic or septic shock. Okay, we do not use dopamine in the presence of a patient who has hemorrhagic shock as a result of trauma. We'll talk about why that is in just a minute. Keep in mind that dopamine is similar to not only norepinephrine that we talked about, but it is also very similar in chemical structure to epinephrine as well, because remember, it focuses in and it acts on both the alpha and the beta 1 receptors. When we're looking at the alpha 1 receptors, remember, it takes the periphery and begins to cause vasoconstriction. When that happens, our patient's blood pressure should go up. Its effect on the beta 1 receptors causes a positive inotropic effect on the heart. Here's the nice thing about dopamine is that we can use dopamine, we can use epinephrine to both cause a good positive inotropic effect on the heart, but dopamine does not raise the myocardial oxygen demand of the heart to the same level as does epinephrine. Here's the other thing you got to remember. Dopamine really does not have any effect on the chronotropic effect of the heart. All right. So now again, let's kind of go back there and remember, dopamine chronotropic refers to heart rate. Inotropic refers to in and out, contractile force. And dromotropic refers to how fast the impulse is going through the heart. That's why it's really important that you review these types of words and you get really good familiar on those. It begins in about 5 minutes, but the half-life is really, really short. This is why when we start a dopamine drip, we leave it running until we get that desired effect. When do we give this? We give it when our patient has significant hypotension as a result of either cardiogenic shock or septic shock. Eli, do you have a question? You unmuted. I just want to make sure you didn't have a question.
Can you hear
No
me?
problem. Yep, I can now.
Oh, that's not good. Hold on.
No, I can hear you now.
Oh, okay. No, I didn't have a question. No.
Oh, okay. Not a problem. Not a problem. All right.
Would you,
So, yeah, go ahead.
would you mind going back just one slide? I missed all of those pharmacokinetics, every single one.
Uh-huh. Now, again, a couple things to remember is number one, these slides are in Blackboard. If they're not, please let me know. And number two, if you didn't get a copy of these, don't waste your money printing them off because there's a bunch of them. Let me know and I'll print them off on our printer because I don't want you spending any more money than what you absolutely have to. Did you get all those?
Yes, I did. Thank you.
All right, good. So again, why do we give it? Cardiogenic shock. Some of the side effects that we're going to see here, or some of the contraindications, is we do not give dopamine when there's a volume problem. Okay. Do not give dopamine when there's a volume problem. That means if our patient is bleeding out, if they have extensive burns, simply because it's just not going to be good for your patient. Because again, especially if our patient is bleeding, think about what would happen if we caused vasoconstriction. We could potentially increase the rate of blood loss from the body as a result of that particular situation. These are your side effects. We can get all kinds of FOBs from our patient. Our patient will often feel like that maybe they have a little bit of chest pain is going on in there. And it can also cause blood pressure to go up. Now, here's the thing you got to remember about dopamine, okay? When we give dopamine, somebody, especially if you don't have it set up on a pump. One of the things that just thrills me and had been a frustration up until the last few years is that ambulances didn't carry IV pumps. So we relied on gravity and our mathematical abilities, both of which can be suspect, especially if you're talking about me, to deliver IV drips. If we let a dopamine drip get away, we can actually cause vasoconstriction so tight that it results in our patient having a stroke. Here's the other thing that you want to remember about dopamine. Your dosing regimen for dopamine is going to be 2 to 20 micrograms per kilogram per minute. So it's a really, really potent drug. One thing to remember, if we start less than 2 mics per kilogram per minute, it actually causes vasodilation of the renal artery. Now let's think about this for a minute, because that could be a really, really good situation if we use it in the right conditions. Under what condition do you feel like that it might be good to vasodilate that renal artery?
Be conditions of renal failure.
Yes. Yes. So what we're looking at here is if we've got a patient that has acute renal failure, which basically we're not really sure why, most of the time it's going to happen because of a sudden spike in the blood pressure. Or the other situation is if our patient has massive burns, we can start 2 to 20 mics. Now, remember, I just said a while ago, we're not going to use dopamine in a patient with burns. Well, we're not going to use it to raise their blood pressure, but if their blood pressure is fine, and remember, one of the problems with a patient with massive burns is that the protein gets broken down, it goes into the kidney, and it globs it up, and the kidney begins to fail. If we give dopamine at less than 2, and generally what I would tell you to start out would be 1/2 to 1 mic per kilogram per minute, we vasodilate that renal artery, and we may keep that patient off of dialysis by doing that. Trust me, I've been on dialysis twice in my lifetime. It is a long-term process, and your patient never feels good. So that's why it's really, really important. Here's the other thing is that dopamine, and if you're going to give sodium bicarbonate, don't give them in the same arm because sodium bicarbonate will inactivate dopamine. So it'll make it completely useless. Okay. The other thing to keep in mind is if your patient is taking an MAOI inhibitor, a monoamine oxidase inhibitor, which is a type of an antidepressant, watch and definitely start down at the lower dosing rate for your patient, okay, because it intensifies, it has a synergistic effect. Questions on dopamine?
Yes, sir.
Go ahead.
Is there a better pressor for cases of trauma than dopamine?
Well, with trauma, what we're going to do is we're going to fluid replacement. Okay. And so with trauma, what we're looking at to raise the blood pressure is primarily giving them a fluid bolus to get our blood pressure up to between 90 to 100. Again, we don't want to blow those clots out. But remember, the downside of giving fluid is that it does not carry oxygen. So in lieu of that, you would administer whole blood in conjunction with a fluid bolus. But generally, what we're not going to do in hemorrhagic shock, Travis, is that we're not going to give a pressor. However, that leads me into our next drug, which we can use as a not only a sympathetic agent, but we can also use it as a good pressor for our patients is epinephrine. Epinephrine, we know our body secrete it. When the body secretes it, we call it adrenaline, and it has both alpha and beta 1 and beta 2 properties. Its effects on the beta receptors is a lot more impactful than what we would see on the alpha receptors, but that does not mean that it doesn't work at all. Generally, what we see here with epinephrine is it increases the heart rate, it increases the contractile force, it increases the electrical activity in the heart. So our dromotropy, our conotropy, and our inotropy are all positively impacted. But wait, there's more. It will cause systemic vascular resistance. Basically, all of the blood vessels will now begin to contract to raise our blood pressure. It also increases automaticity in the heart. Now, the interesting thing about it is that the beneficial effects of epinephrine and cardiac arrest are actually more due to the vasoconstriction or the alpha effects than has been the beta effects. But now here's one thing to keep in mind. The administration of epinephrine has been shown to dramatically cause our patients to have an increased rate of ROSC, return of spontaneous circulation. But there is no indication that our patients have an increased possibility of leaving the hospital under their own power as a result of administration of epinephrine. So generally, it does not translate into a longer survival rate for our patients. Epinephrine is an old drug. It's been a mainstay of cardiac arrest, and it is still given on a regular basis for our patients in cardiac arrest. Generally, what we're going to see as far as onset is that it's going to go to work really, really quickly. Okay. Disregard this as far as giving it down the endotracheal tube. We just simply don't do that anymore. And this is one of the situations where I got to jump in there and edit these slides. So it starts really quickly, but here's the thing you got to remember. It's got a half-life of about 3 to 5 minutes. So it will literally wear itself off pretty quickly. When do we give it? What are the indications? From a cardiac perspective, we use it in asystole, VFib, pulseless VTAC, and any type of severe anaphylaxis. We can also utilize this when we've got a patient that is having status asthmaticus. Basically, status asthmaticus is kind of like status epilepticus. It's an asthma attack where nothing that you're doing is causing those bronchioles to be able to dilate. And so we can utilize that really, really well in that. If we get a patient that is refractory, there's that word again, refractory to atropine in symptomatic bradycardia, we can also utilize that as a backup or a secondary drug for our patient. There's no contraindications in the emergency setting. And here's the thing to keep in mind. We all have adrenaline that we're producing. Without it, we die. A patient will not be allergic to the adrenaline. However, a patient may tell you they have an allergy to epinephrine, and actually what they're telling you is that they have an allergic reaction to the additives, the preservatives that is in that particular drug. So you want to kind of keep that in mind. Because epinephrine is a catecholamine, we don't want to keep it exposed to light or heat. Okay, light and heat. So we want to keep it in a cool place, keep it in its box. If you get a multi-dose vial, you'll notice that the multi-dose vial is going to be a brown color to help dissipate that light. It's a catecholamine. Catecholamines have, just like I said, positive dromotropy, positive inotropy, positive chronotropy, but it also can be deactivated by sodium bicarb. So if you're going to give sodium bicarb, make sure you've got 2 lines going, one in each one of the extremities, and make sure that they are labeled so that you don't get them confused. Because if you're giving sodium bicarb and epinephrine in the same line, it's going to inactivate the bicarb and make it completely of no use. Side effects that we're going to see here are going to be those of activation of the sympathetic nervous system. Heart rate's going to go up. Maybe they're going to have some anxiety because they're going to have vasoconstriction, reducing a little bit of the blood going to the brain. Potentially have a headache as well as nausea, vomiting. Now, it's becoming very, very common to use what is known as push dose pressors. Now, what you're seeing right here is this is the dose for cardiac arrest. We're going to give 1 milligram of 1 to 10,000 solution. Remember, epinephrine will come in a 1 to 1,000 or a 1 to 10,000. This is not as concentrated as what the 1 to 1,000 would be. But in cardiac arrest, we're going to give 1 milligram. That's generally going to be 10 milliliters of this 1 to 10,000 solution, and we're going to repeat it every 3 to 5 minutes. Now, as we said, it's becoming more common to use what's known as push dose pressors in the management of shock when our patient becomes symptomatic. Push dose pressors is basically, we're just going to give little squirts of a catecholamine. Most of the time, it's going to be epinephrine to raise that blood pressure. Now, you may be asked on your exam about the use of push dose pressors, but I won't ask you to calculate how you're going to do that until we get farther into to ACLS. But I do want you to know that basically what happens is that we're going to give this small squirt, this small amount every 1 to 5 minutes. And even with that, you're not going to have to remember about as far as the dosing. Just understand that a push dose pressor at this point in time in your education, a push dose pressor is just a small amount, a microscopic amount of epinephrine that's given periodically. All right. That is where we're going to stop. It's a little difficult to have the same type of class as what